Welcome, everybody, to our webinar on health literacy and medical respite care. We are going to get started in just one moment. We're going to make sure that everybody has a chance to transition in from whatever else was happening in the rest of their day, your day, whatever's happening there. So we will get started in just a moment here. All right, we are looking pretty good here in terms of our waiting room. So I'm going to go ahead and kick us off. And then Laura, if you want to get your PowerPoint pulled up, you can do that while I'm doing just a few moments of housekeeping.
Okay.
Welcome everybody to the webinar today on addressing barriers to health literacy in a medical respite setting. I'm super excited that we have a great group of presenters here to talk about what this has looked like for them in their medical respite care program. Before we dive into the content, just a couple of housekeeping reminders. This session is recorded and will be shared out to attendees and posted on our website for access. We will not be posting the full PowerPoint slides, but we'll be posting some of the tips that the team is going to go over at the end. If you have any questions while they're presenting, they have built in a lot of time for case discussion at the end. So throughout the presentation, feel free to share your questions in the chat. I'll be monitoring those and we'll be able to get to those when we get to that point in the session. If you have any tech issues, feel free to message me. I'm happy to help try to troubleshoot that. And with that, I'm going to turn it over to the folks from Central Health to introduce themselves and kick off our content for today. Thanks for being with us.
Hello. My name is Laura. I'm the nurse manager for Central Health's Medical Respite Program in Austin, Texas.
Hi, I'm Cecilia. I'm former medical assistant for Respite. I'm currently one of the supervisors at our new medical respite facility.
Hi, my name is Teresa, and same as CC, former medical assistant, but now part of the respite community staff.
So yeah, we'll get started. Our presentation today is about barriers to health literacy, specifically to a medical respite setting. So medical respite being a place for people experiencing homelessness to recover from an illness or an injury. So our program is based out of Austin, Texas. We started in 2022. We started with 23 beds in a couple of shelters around town. We are funded by Travis County's healthcare district, so an insurance program called MAP that's funded by property taxes. We have 2 nurses, 4 MAs, and 2 case managers, and we're all under a provider named Dr. Kwong. Average length of stay for us is about 2 months, sometimes much longer than that if somebody has a complicated plan of care. For example, if they have cancer and they're getting chemo and radiation, or sometimes it's pretty short. So if they have something like a colonoscopy that they need to do. Most of our referrals come from hospitals, our street medicine team locally, or community clinics like our clinic that serves people living with HIV. And then we also get a lot of referrals from skilled nursing facilities. So we were out of shelters primarily, but we just moved into our own big shelter. The first floor is a shelter, and then the 3rd floor is a clinic. And so we went from this tiny box that we're in to a giant building very recently. There's some bats. So before we kind of launch into our content, I just want to have y'all look at this typical discharge summary and kind of think about if you have any issues understanding the directions here. Does it make sense to you? Does it feel wordy and overwhelming? And do you know what everything in this discharge summary means? Do you know what it means to elevate the affected extremity? What does extremity mean? Do you know what an ice compress is? Do you know how long to put on an ice compress, or how to monitor for a cold injury if you leave it on for too long? Just think about ways that this typical discharge summary might be confusing. So I'll just give you a minute to read it. Okay. And then here's another type of discharge summary that's a little bit more accessible. It's in simpler language. It has universal symbols like a sun and a moon. And it has very easy to follow directions that are in really basic language. So today during this presentation, our hope is that you have a chance to kind of think about the individuals that you work with at Respite or in a clinic or in other settings, and kind of increase your awareness of health literacy challenges that people might face who you're interacting with. And we'll share how we assess for health literacy barriers in our environment, which is medical respite, and then how we're working to improve health literacy for people while they're in our program and how we work on skill building. So here's a couple of true or false questions that you could answer out loud or in your head. Health literacy correlates with education level. Providing written materials is enough for providing patient education. And patients will tell me if they can't read. So think about whether or not you guys think these answers are true. Health literacy encompasses various skills, including finding, understanding, and using health information in different formats. So written discharge instructions, spoken instructions from your doctor during a visit, visual instructions. So it's not just about your reading ability, but it's also about numeracy, your ability to understand numbers, technological skill, whether or not you're able to access something like my chart or have access to a computer, and also the ability to navigate the healthcare system. Materials need to be accessible, culturally relevant, and actionable. So the directions for next steps need to be really clear. They need to require additional support like spoken explanations or digital tools if people are not literate or are visually impaired. I'm going to hand it over to Cece to just kind of go over what our definition of health literacy is.
Alrighty. So the book definition is that the degree to which individuals can find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So a simplified way of this is not just about whether can someone read or write, but more broadly, can someone find, understand, and use the information? Now that we know what health literacy is, what is health numeracy? It's pretty much the same concept, just involving numbers. So the degree to which individuals can find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So not just about whether can someone read or write, but more broadly, can you identify numbers and correlate them to your health? So like, will somebody understand, a blood pressure reading, a heart rate reading, an O2 status? Okay. Fast literature review. So learning barriers to impact health outcomes. Untreated vision and hearing impairments are associated with a significantly higher risk of hospital delirium and increased fall risk. Critical ill patients with limited English proficiency spend a median about 17 to 35 more minutes in the ED before they're transferred to an ICU due to lack of understanding. People with cognitive impairment have a higher risk of elderly death from all causes. So what is the impact of limited health literacy? So some of these may include medication errors, difficulty understanding and following care plans, reduce of preventative services, challenges managing the complexities of chronic conditions. Other things we have noticed, patients are getting lost to and from their appointments or within medical facilities. Some of these medical facilities are hospitals, they're full of different departments, different emotions. Some patients might feel some frustration, some apathy, lack of trust in the system as a whole. Some might even say, no one explains anything to me, so I'm just not gonna do it. Some of them have difficulty asking for help, whether from embarrassment, cultural norms, or trauma response from past bad experience.
And this is something that's been researched a lot recently, is chronic disease or chronic illness burnout, that people just get so burnt out from their chronic illness that it makes it difficult to learn.
Alrighty, so we have some questions. What % of the US population is proficient in health literacy? You guys can take a guess. We'll go ahead and disclose our answer in just a few seconds. So only 12% of the US population is at the proficient level of health literacy. I know this number can be very low.
So when we think about health literacy, we often think about it as, can this person read or write? But we found that literacy encompasses a lot more than that. So reading level is definitely a part of the patient's health literacy, but it also extends to how or if the patient can comprehend the information that they're reading. So for us, what we're really trying to cover for is the four senses. Can they see? Do they have visual impairment? Are they able to hear what's being taught to them? Do they speak the same language that the information is being shared in? And then also, do they have the cognitive ability to comprehend this information? Is this something that they're capable of to understanding this information? And if not, do they need some support? So here's a snapshot of our respite patients, just from one period of time of, I think, 3 months. We took 25 patients and we asked them about their visual status, their English proficiency, hearing, and literacy. 72% were visually impaired, and of them, 4% were legally blind. 20% had limited English proficiency, and we measured that by asking if they're comfortable having a conversation in English at a clinic or at the hospital. 24% were hearing impaired, and 64% had some kind of literacy challenge. So that was dyslexia, an intellectual disability, or pre-literacy. They were not able to read past a 3rd grade reading level. So yeah, this is just kind of a little snapshot about how people experiencing homelessness can be impacted even more than the general population when they experience barriers to health literacy. They have poorer outcomes and a disproportionate burden of disease and disability just from not being able to follow up on their discharge instructions or their medical plan of care. We want to touch on health literacy specifically in populations that we all serve, which is unhoused individuals. We know that health literacy affects everyone, including people who are at high education levels, have great access to resources, have housing. But how does poor health literacy further exacerbate the challenges that the unhoused population already face? We know that experiencing homelessness itself affects health, and we see this in how our patients can have poor follow-up care, increased problems post-discharge, increased ED utilization. And then, for example, somebody gets discharge instructions that say change your wound dressing 3 times a day and wash it with this type of soap. Do they have access to a sink? Do they understand the directions for changing their dressing? Do they know which layer of the dressing comes first? All of this stuff is dependent on one little piece of paper that they have. So these are some pretty common questionnaires and surveys for assessing health literacy. None of them were quite perfect for our purposes, and so we created our own. But we'll just go through a couple of the options that are available, and then we'll show you what we used in our program. So the first one is the Realm survey. This one only really measures a patient's ability to read medical terminology, but it doesn't assess a patient's ability to comprehend what they're reading. And it's also only available in English. This questionnaire is probably the most common worldwide. It's available in multiple languages. And this one helps not only to assess if the patient is able to read, but if they're able to comprehend and understand what they're reading. So for example, do you know what your prescription is, and do you understand the directions? If it says, take it 2 times a day, does that mean take 2 doses in the morning, or do you take it every 12 hours? This one's the brief questionnaire. So this one's a self-survey that patients can answer if they feel embarrassed talking about literacy face to face. So this is a good way to self-report and to provide privacy and dignity. This is how we've created our own intake in our electronic health record for our medical respite program. It combines different aspects of all of those forms, plus questions that we have found to be personally useful. So here's a snapshot from our EHR. We phrase it as, when you get discharge paperwork from the hospital or from the clinic, is there for any reason difficulty for you reading it? So we assess, do they have dyslexia, untreated vision loss, are they hard of hearing, pre-literate, language barrier, cognitive barrier? And then when you click on these, it reflexes to a couple more questions about each category. So for our intake, phrasing is really important. We'll ask, do you have blurry vision that makes it difficult for you to read your pill bottles? So sometimes if we say, can you see? That person might say, yeah, I can see. But what we're trying to get at is, can you see well enough to read your discharge instructions and to safely read your pill bottle? And we ask, do you have trouble hearing what people are saying to you? So that's a big one, especially if they're going to a doctor's appointment and they're trying to retain information. If they're hard of hearing, we're going to need to call ahead and make sure that the staff know that they need to be communicated with in a different way than just verbally. And then, what is your preferred language to be spoken to when you're receiving information? So some people are able to get by in English, but that doesn't necessarily mean that that's the best language for them to receive education in. And then we also ask, have you ever been in special education when you're in school, or have you ever been told that you have dyslexia? So part of our intake is we go over this pill box. And then we can modify the pill box if it's not in English, or if it's in English and the person needs a different language, we can modify it with a Sharpie, or we can put stickers on it that say morning sun or evening moon. And then this is also a good time for us to do skill building. So talk about what the medications are, what are they used for, when do you take them? And we can also go over discharge paperwork at this time and practice filling pill boxes. according to whatever their changes are. So this was just about a little bit more skill building. We go over how to call for appointments, how to call for medication refills, and troubleshoot issues with insurance at the pharmacy, and then how to call for rides with what we have in Austin. It's called Metro Access. So we help them call for a ride for mobility impaired services. So I'm going to hand it over to Teresa and Cece, and they're going to go through a couple of scenarios that we've experienced in our program, and we'll talk about how we handle those situations, and then we'll also kind of poll y'all about some of your ideas for how you might handle these situations.
So our first case study up is in regards with vision. So G is a 62-year-old male who admitted to a respite program with severe bilateral cataracts. He was not able to see any detail beyond large shapes. G had 14 medications he needed to take daily, including a blood thinner that could lead to severe bleeding if taken incorrectly. G used a shared bathroom in the shelter and frequently went into the wrong dorm, believing it was the bathroom. Had trouble accessing public transportation or Lyft because he couldn't see his phone or bus signs.
Yeah.
And then, so there's a couple of questions. You can leave a comment in the chat or think them to yourself. What are some barriers to health literacy that G is experiencing? What are modifications that we can make to his environment to support him? And what are some systemic changes that could have been implemented to help G manage his health with his limited vision?
And Caitlin, if anybody's saying anything cool in the chat, feel free to read the responses. We'll just wait a couple seconds.
Perfect. And then would you be able to go back one slide so people can see the case study for another moment? Awesome. So, and a reminder for the questions they posed of thinking about the barriers and then also some strategies that could have been used for this individual. All right, so I'll read there's a few responses in the chat. Somebody noted that there's definitely confusion evident on the part of the individual. And someone suggested a pill box with an alarm and a timer for medication management if they're able to access one. Somebody else also suggested a pill organizer, which is one of my favorite strategies, so not surprising that got mentioned here.
Yeah, there's some great ideas, and then we'll go over some of the things that we implemented within our program. So we use the textures, colored stickers to place on G's medication to help differentiate them between, for example, like doorknobs to the bathroom, so you wouldn't go to the correct restrooms, and also like common living areas for easier access. So for example, back to the bathrooms, we would put a texture sticker like on the hot tap water, so he'd know which one's differentiate from the cold and the hot one. We use also phone calls rather than like text messages to remind patient of appointments and especially like ride reminders. We notified in the cafeteria staff that G needed more time in line and assistance when it came time to meals. Just because of the whole vision impairment was notifying the staff beforehand was really helpful. G was able to successfully, at the end, he was able to complete his cataract surgery and both of his eyes, and he regained his vision. And this is G.
Yeah, that's it. That's G with his new vision, new eyes.
Ready for our next case study. This one's more about literacy and alias D. So D is a 29-year-old male who was admitted to the medical respite program after being found down in a diabetic coma. He sustained third-degree burns to his face and hands from lying unconscious on hot pavement for several hours during the summer. He was diagnosed with type 1 diabetes as a child, but has not had minimal medical follow-up apart from hospital admissions for DKA. D is unable to read or write, and his highest level of education was the 5th grade. He also struggles to see clearly due to diabetic retinopathy. D struggles to manage his diabetes. He reports most of the education he has received has been from pamphlets and educational handouts from his hospitalization visits. D received updates, an updated dosage of long-acting and short-acting insulin at his discharge, but he is unable to read which is short-acting and which is long-acting. But he can choose appropriate numbers of units for dosaging. So back to our discussion questions. What are some barriers to health literacy that D is experiencing? What are modifications that we can make to the environment to better support him? And what are some systemic changes that could be implemented to better manage his health within his limited literacy and diabetes management?
We'll just give y'all a minute or two to just reread, and if you have any ideas, Caitlin, feel free to read them out.
I see a suggestion, a talking meter.
Ooh, that's a great idea.
Yeah, also insulin pumps or CGM plus pump.
Mm-hmm.
Another endorsement for CGM. I don't know if I'm not a nurse, so folks who maybe want to share what that acronym is.
Oh, continuous glucose monitor. So yeah, he did end up getting one, and it was a game changer for him. So good ideas, y'all. You and his endocrinologist nailed it.
Right. Yeah. And I'll highlight somebody also added a therapeutic relationship with a trustworthy endocrinologist to help adjust that. So that was a great transition for you all.
Yeah.
So some of the things that our Respite team did to help was indeed we set him up with a Freestyle Libre device for easier monitoring of his glucose. We created color-coded reminders about his insulin. So like an orange versus a blue, which one was short-acting and which one was long-acting. We set him up with a designated diabetes management table in his room with all the supplies he needed. We engaged staff in helping with reminders. We used pictures and videos for education, for his better understanding, and we did daily reminders and education with teach back method, which we'll talk about later in the slides.
I'll highlight one more suggestion from the chat. Someone thought maybe if there was a way to create a flag in the electronic medical record to emphasize the patient is blind and would benefit from video or audio education, might be a good flag to put in their chart as well.
Yeah, that's
Yeah,
a great one.
definitely.
Super important.
All right, so our next one up is C, is a 27-year-old male with epilepsy and intellectual disability. He has 1 or 2 seizures per week and only takes his anti-seizure medications when prompted. His frequency of seizures has led to other health issues, such as a broken jaw and multiple wounds. C can read small words, but struggles with comprehension and memory. C left the respite program because he was approved for permanent supportive housing, which is a good thing, but he aged out of his other supportive services as he has no medical documentation of his IDD, apart from his high school records showing that he was in special education. So he is not eligible for custodial care. And then back to those same questions. What are the barriers to health literacy that he's experiencing? Modifications to the environment to support him, and any systemic changes that could we do to help C manage his health. And we'll go back to the slide. And same thing as before, if you guys don't mind. You guys want to put something in the chat?
Yeah, we've got one suggestion already, asking if he knows when the seizures are coming on so he can get to a safe place or location.
Yep.
So we'll go to what we did to help support C.
And then some things we started to do, so with the respite team, we accompanied patients to all appointments to advocate for patient and provide instruction. Sometimes that extra person in your appointments, that one you trust, it's really helpful for not only the patient, but also it also comes back to that teach back method at the end as well. Did I understand everything they told me? And if not, I have somebody else that I could trust that could explain that to me again. We used images to help patient understand more complex instructions. So like, for example, we said before, the sun and moon to indicate day and night for taking medications. Also a reward system to motivate patients to complete tasks and health-related needs. We also set an alarm on his phone with medication reminders and set up the patient with case management services after discharge with a warm handoff.
And so, for non-medical people, a warm handoff is just so if I'm handing off his care to Teresa, we're gonna have a conversation on the phone. I'm not just gonna send her like an email.
Alrighty, so our next case study is regarding the language barrier. This is for alias Jay. So Jay is a 52-year-old Spanish-speaking male who admitted to our program after a below-the-knee amputation. He went to the ER over a holiday weekend for an infection to his thumb incision. He was discharged with a paperwork script in English, discharge instructions in English, and follow-up instructions in English. No translator or proficient Spanish speaker were utilized during his visit. This hospital where Jay went has an in-house pharmacy, whereas antibiotics could have been picked up if he had been given instructions in Spanish. Jay did not begin his antibiotics until his case manager was able to assist almost 3 days later. Okay, so same questions. What are some barriers to health literacy that Jay is experiencing? What are modifications that we can make to the environment to better support him? And what are some systemic changes that could be implemented to help Jay manage his health, given his language barrier? We'll give you a few seconds. If you guys have any ideas, please share, and then we'll let you guys know what we did to help him.
Sure, yeah, we have one suggestion in the chat to educate the patient that he can request for translator services at medical facilities and that it is his right to be able to do so.
Heck yeah, that's what I'm
Absolutely.
talking about.
Let's
Lots
go
of
over
thumbs
what
up for that suggestion.
Yep.
Let's go over what we did. We sent Spanish-speaking staff with patient when possible to advocate at appointments for him. We encouraged him to ask for translation when necessary. We would call ahead to the providers and hospital staff to ensure accountability in terms of translation assistance and request that medication labels, discharge instructions, and follow-up appointment instructions are all provided in Spanish. We provided Jay with a Spanish pill box, and we also would give him some Spanish education regarding his health issues like diabetes and wound care. This is Jay.
That's his hat that he never takes off, even to shower. So yeah, just to sum up, what we've noticed with our efforts to improve health literacy are improved independence in managing, people managing their health needs, improved engagement. They feel empowered to take more ownership of their own health and to explain and educate others about their own health. And then it also helps build trust and trusting relationships with the healthcare system in a population that often has a lot of medical mistrust and also medical trauma. So we'll just go over our top 10 tips for addressing health literacy barriers. The first one is to use short sentences and to speak slowly and pause for clarification. So for example, using an insulin pen, we're going to say, select the number of units on your insulin pen by twisting the pen. You'll hear it click 3 times, 1, 2, 3.
Alrighty, our second tip is to organize information so that the most important points stand out and then repeat this information. So for example, your appointment is next week on Wednesday. It is at 9:30 a.m. Your ride is coming at 8:45. The clinic is on the 3rd floor. So on this precise sentence, we would emphasize that his appointment is on Wednesday. We would highlight Wednesday. And then we would highlight the 8:45 time because that's the time when he should be ready for his ride.
And then a third tip, use universal symbols, as we said before, but for example, cupcake for medication that treats with blood sugar, heart meds that treat blood pressure, and a sun and a moon to differentiate day and night.
Yeah, so we love stickers here at our medical respite. And then the other one is number 4 is supplemental instruction with appropriate material. So for example, if Teresa is not able to understand written materials and she has a bulged disc, I can show her a diorama or a model of a spine, and I can show her what it looks like, what her bulged disc is doing, and she's able to visualize that information and comprehend it without having to have this paperwork that she can't really conceptualize.
For our fifth number tip for today is to ask questions that begin with how and what, rather than close-ended yes or no questions. So instead of asking, are you taking your medications? We could ask, how have you been taking your medications? Just to ensure we have an understanding by their response if they're able to do it or not.
And to piggyback from that tip, we ask for 6 when we ask patients to explain your instructions. For example, using the teach back method to demonstrate the procedure. So instead of saying we could say, show me how to use your inhaler. Show me how do you pack your med box, instead of just answering, hey, do you know how to use the inhaler? And then just yes or no, will you use these instead?
We encourage patients to ask for translation services, and then we also will do some coaching with, I don't understand, please help me get a translator. So helping people learn that sentence so that if they go to the emergency room or if they go to a clinic, they know how to say, I need a translator. And because what we have found is that a lot of times providers who speak a very small amount of Spanish will try and get by explaining things in limited Spanish. But they're not really providing great patient teaching without a translator. And the most appropriate thing is for them to get a translator.
All right, for tip number 8, it's using plain language. So not using medical terms. So instead of stomach, or we could use stomach or belly instead of abdomen. And here we have a picture of a few others that we could use. Like instead of RX, we can say prescription. Instead of sutures, we can say stitches. Instead of systemic, we could say whole body.
And then we use like we said before, we love using stickers. But specifically the texture stickers or the color stickers for individuals with visual impairment. For sure, those have been really helpful for our patients and our folks. And also, we love stickers too. So we haven't said it before.
The big one is we try and advocate for our patients whenever we can. So if somebody's going to be going to the ED and they have any type of barrier, we call ahead, we talk to the charge nurse, or we talk to the provider in the ED, and we kind of explain the situation. And then whenever possible, we accompany patients to their appointments, especially if it's a specialty visit that's going to require a lot of follow-up, or they're going to be receiving a lot of complicated information. So then they just have someone else there to advocate and to write down the information so that then we can relay it to them in a way that is easier for them to understand. Here's our references. Okay, that's our spiel.
Great. We had one suggestion in the chat that I'll highlight around the translation services of also providing folks with a pocket card that states I need a translator and the language that's needed as another backup resource. So
Ooh, I love that.
yeah, a lot of collaborative problem solving here. We did have a couple of questions in the chat while you all were presenting, so I'll start with those, but we definitely have plenty of time, folks. If you have additional questions, go ahead and throw them in the chat, or you can use the raise hand feature, because I think we'll have time to get through a few. But somebody did ask if you could talk a little bit more about folks who are visually impaired within your program, just in general, how they get around in respite and how they're able to adapt to that particular setting.
So yeah, we've had several people needing cataract surgery, who come to the program, and we make sure that they have a walking stick, and then we make sure that we let staff know that they're visually impaired so that staff can help with anything that's going to be hot, coffee, plating food, hot taps, and then we'll put textured stickers on the hot taps so that they know to be careful. And then we put textured stickers on the doors to their room and to the bathroom so that they can feel the sticker and know which is the appropriate door and they're not accidentally going into the wrong dorm. And then we also put a sticker on the flusher for the toilet.
I want to know y'all's budget line item for stickers in your program. Has to be a separate set of resources. Great.
Yeah.
Another question that was in the chat was also, do you look into brain injury as a cause of limited health literacy for folks that come in the program?
Yeah, we've had several people with TBIs come into the program and cognitive barriers because of other things that have affected their brain. And for them, we try to do a lot of in-person advocacy, so trying to send people with them to appointments.
And I feel like a lot of just constant reminders as well with staff, and even with you could say, like, even if they're around patients, just be like, hey, cautious, this person has a cane, or how you're like, cautious, this person has a walker, could also be helpful, not necessarily having to release any PHI.
Yeah.
And on that, I think we focus a lot on like the teach back method, but also we try and teach all of our participants and patients so that they can successfully, take care of themselves when they do exit our program. So most of our time we are spending a lot of time teaching them and just making sure that they get a good understanding on how to take their medications and how to understand their
Plan of care.
Plan of care, yes.
And we have had a couple people that we just had to kind of accept that they will always need help because of their TBI, and they're not going to be able to live by themselves safely. And so in those situations, we've tried our best to get them into long-term care or a group home.
Great. And a related follow-up question to that, I think related to brain injury and cognition in general, is does your team perform any formal cognitive assessments?
Yeah, the big one that we use is the MOCA. The MOCA, and then the MOCA is adaptable. There's a MOCA blind, and then there's also a MOCA for people who are pre-literate.
Great. Yeah. And I am looking for a link. We have a resource and we did a webinar around addressing cognition in medical respite care. I guess a couple of years ago now, I've lost track of time. So I'll link that in the chat for folks who are interested in exploring what that can look like a little bit more as well there. Before I do that, I'm going to throw out another question that came up in the chat is any strategies that you use for folks who are unable to self-administer? I think this is related to diabetes and insulin.
Yeah, that's been a difficult one, especially for people who have recently had strokes and they have like maybe a flaccid hand. Yeah, we haven't found an amazing way of managing that yet, to be honest.
I'll throw it back to the group. Does anyone in the group have any ideas or ways that they found that have been helpful to manage that? We do have some really experienced folks here as well.
Let's see.
Go ahead, Annie. I see ya.
Okay. This was something that I did with my parents is I got one of those little toolboxes that has the drawers in it. And so each drawer had the medications for the day in it. And my mom was able to master that. And I would call her, said, time to, and my dad's insulin was in there as well. And it was so easy because a lot of the medicine boxes, they're hard to open. And having the drawers, Monday through Friday, there was a row for the evening and the morning. And that was an easy way to get into the medications. And on the front of the drawers, it was palpable the day of the week. So you could actually feel with your fingers, that big M, et cetera, just because there was, some problem with vision, so some limited vision. So
That's a great idea.
Yeah.
Thank you.
you're welcome. I just also wanted to comment that I loved your little squishy spine. That was great. And I know that in my office, I would have lots of pictures of spine, the body's organs, and just teaching people where things were. And so, like, you could look at the heart and you say, this heart is pumping, and see how that red line goes to the kidneys. So sometimes things get kind of backed up in there, and just being able to visually show where people's, issues were, and particularly in the pelvis for women who didn't know which side their appendix was on, where their ovaries were, where the uterus sat, and then also attaching the medication name and what it's used for, and how it was addressed on this particular chart of the human body. So people have a visual concept of how it all works, because most people don't really know.
Yeah, and so many people are not auditory learners. They're not going to absorb anything that you're saying, but they will if you're showing them something visual.
Yeah. And with a lot of our guys were in the trades, and they understand about electrical, they understand about plumbing, et cetera. So, using those concepts and that, the ability to understand those systems, which often are not that different than our physical systems. So,
Yeah.
Great. Thank you, Annie. Yeah, and somebody shared in the chat, to Annie's point, I keep an old medical anatomy atlas in the clinic area. It's a quick, easy tool for patient teaching. And I love that too, because, even like somebody just sort of sitting there and flipping through it, right? Like I'm somebody bored in the doctor's office, like I'll look at the charts on the wall because there's not anything else going on. So yeah, love having all of those different ways to enter that information. One other question in the chat, somebody noted that they are a respite nurse and would love to learn when is the most ideal time or the ideal person to do med education with patients. It just gets so busy. So does anyone have the secret to more time? If not, we'll see, Laura, how you all address patient education.
For us, it's just repeating during our visit. So we do our intake visit and we try not to front load with too much information. So when somebody comes in, we'll do the pill box for them. We just go over the meds and do a very brief med rec, but we don't try and put too much teaching on them. And then at their follow-up, the next nurse follow-up, we'll practice with the pill box. And then that's kind of when most of the skill building happens. Is I'm watching Teresa fill the pill box. And then as we're doing it, we're talking about frequency, we're talking about the med, and we're talking about what the med is used for. And so the skill building and then the med teaching is just happening at the same time. Does that answer the question?
I feel like it. And again, we've got a group of folks here who also are doing some similar things. So anybody feel free to jump and add in if there's other ways or strategies that they've addressed that. But, you know, I think that is such an important point of like that repetition, right, is so important because most of us don't learn like fully learn the first time that we're taught something, right? And so that repeated practice over time to emphasize those points and even just build self-efficacy around the knowledge can be really, really important because we never know how much folks are absorbing and intake. There's a lot that people are sort of like adjusting to at that moment. And so being able to repeat that continually for folks, I think has a lot of benefit. So
Yeah. And Teresa and Cece are both really special in that they're extremely encouraging. And so people love to come and brag about, I know what this is for to them in the office. So that's kind of part of their teaching style too, is that they'll be like, okay, what's this for? And then they'll say, that's for my cholesterol. And then Cece and Teresa are like,
yeah, exactly. You know, building that, you know, just internal sense of confidence, I think it goes a really long way for people in terms of learning, right? That if we're confident in our knowledge, that helps being able to build on that and motivation to be able to continue that, right? It's all linked together. So yeah, that's a huge piece of that and why medical respite is so important, right? In terms of relationship building and having those interactions with folks.
Yeah.
And then someone also shared in the chat too, just like thinking about small doses, that a lot of medical and health information is so overwhelming that breaking that into small pieces repeated often can be really helpful. So
yeah, absolutely.
and then another question in the chat, how do you build in family support or education for the future, if that has come up for you all?
I mean, sadly, I can't think of that many cases where family has been involved with us, which is a bummer. I wish that wasn't true, but yeah, there's not often a ton of family support.
They're either like out of state or in a different country. I know we have had like a couple conversations where we've had to like explain to somebody's mother what the process is and what they're doing at respite and what to like expect once they discharge. Because yeah, sadly we don't really get many family members or friends.
I think that's part of why health literacy can be challenging too, right? Sort of our health systems assume that there is somebody else involved and not always functioning and assuming that folks maybe don't have that kind of support.
There's many times where I've accompanied one of our patients and they think I'm the sister or I'm like the spouse, and I'm like, I'm just I'm just here to advocate for our patient.
To answer Jasmine's question, yes, they manage all of their own medication, so we just do teaching and skill building with them, but they keep their medication on their person and they take it themselves.
Laura, for clarifying. Yeah, I think programs are definitely structured different ways depending on who's on staff and when and what your storage looks like. So Jasmine, your program, you might be doing a little bit more hands-on in terms of distributing medications to folks, where there are other programs where folks have to manage that task independently. And we certainly see a little bit of everything in between, depending on what the program are. Bob was sharing that at their respite, the meds are kept in the nurse's office and clients come to get them at the appropriate time. They're given their bag and then shown what they have to understand what to take and when. So there's certainly sort of a distribution of ways that programs sort of address that, provide the medication and then the education. And a lot of that depends on the staff and that's available and when that is.
Yeah, we have visits a couple times a week with patients, and when they come, they bring all of their pill bottles and all of their pill box, and then we go through the pill bottles, see if they're running low on anything, and then we help them do a pill box refill.
Perfect. I don't see any additional questions, so I will start us in our wrap up. I'm going to plug a couple of different tools and resources that I've dropped in the chat. I did add in a link to the previous webinar and clinical guideline on supporting cognition within the medical respite care setting. I also shared a link to toolkit that we published earlier this year on assessing and addressing health management. So there's resources in there to think from a programmatic and individual level about how to address health management skills, which includes a section on health literacy. So a lot of emphasis on some of the resources and tips that our folks shared today, although this was definitely more in depth, which is why I was super excited to have our friends from Central Health here. I also want to plug a couple of upcoming events. We have regularly occurring Respite Care Providers Network role meetups. We just had one for clinical providers, and this is a way for you all to gather together in conversation similar to our discussion today, to be able to talk through, like, what does your workflow look like? How do we do this? I'm struggling with this particular issue. What does that look like in your respite? They're unstructured. There's not a set presentation that happens, but really just a chance to come together and talk. So I dropped that link in the chat, and you can register for those that are upcoming, and we'll have a new set of registration links for 2026 as well fairly soon. We also have a Respite Care Providers Network all-member meeting on November 19th. Less clinically focused, we're going to talk about 24/7 staffing and what that looks like in programs and how folks address that, who's providing that oversight overnight especially. So if you're interested in that conversation, please join us there. The last thing that I am going to do, if I can find it, is launch a survey. Yeah, there we go. I did it. If you have a moment before you sign off for today, please complete our survey there just to let us know how we did on the content for today. And otherwise, thank you so much for joining us. Thank you again, Laura, Cece, and Teresa, for sharing your expertise and experiences in medical respite. Really thrilled to be able to highlight the work you all are doing, and hopefully folks gain some ideas from each other today on things that they can take back to their program. I'll hang out for a minute in case there's any additional questions and to let folks complete the poll. But after that, I hope you all have a lovely rest of your Thursday or Friday Junior. As I heard on the radio today, we're almost there. Have a great weekend and week, everybody, and we'll see you at our next event. Thank you so much.
Thank you.
Thank you.